Hello Vet Vaulters, and welcome back to another one of our clinical podcasts. This one is from a two-part series that we did with emergency critical care specialist Dr. Rob Webster on anaphylaxis. In part one, over on our clinical podcast series, Rob discussed diagnosing anaphylaxis and how to differentiate it from other causes of shock. But in this episode, we talk about treatment, and there are a couple of key concepts in there that we really wanted to share with all of you. If you enjoy this format, if you listen to this and you go, yep, this is a great way to update my skills and knowledge and keep up to date, then I think you will love the Vet Vault Clinical Podcast. It's 3 episodes per week, one on small animal medicine, one on emergency critical care, and one on smallies surgery. They're short enough that you can consume it on your drive home or in the time that it takes to do just one load of dishes. So we're talking about 20 to 30 minutes per episode, but they're packed with enough morsels of wisdom from our specialist guests that you will always learn something new. Each episode is backed by summarized show notes so you can refer back to it at a later date because we all forget stuff from time to time. If you're curious and you want to try it out, go to thevetvault.com, just our normal website, to have a listen of a few more samples that we uploaded on there. In particular, go and check out the episode by Prof. Jill Madison from the Royal Vet College about the risks of using antibiotics in young animals. This was a discussion that I knew nothing about, and it kind of blew my mind, and I feel it's something that we should really all know about. So go and have a listen, share it with your friends, and enjoy this episode. Have a great week.
You don't give it, you say there's no scientific evidence or whatever, and then the client goes to their local practitioner who they trust, who says, oh yeah, we'll give them this dose, and then miraculously everything clears up. Yeah. And the emergency vet was a bit of a wally.
Hi, I'm Hubert.
This is Gerardo.
I'm Rob Webster. I'm a specialist in emergency and critical care, and I'm an owner and work and practice at the Animal Emergency Service in Brisbane, Australia.
And you are listening to the Vet Vault Clinical Podcast. Well, that brings us to drugs. We'll leave adrenaline for last. Let's go through the other traditional treatments that seem to be falling out of favor. Let's start with the antihistamine. Any use in that?
Yes, you can use that. There's probably and this may be a time where H2 antagonist could be worthwhile, which is ranitidine or famotidine, because gastric acid secretion certainly is exacerbated by histamine release because it stimulates release of gastrin. So I would certainly consider the use of an antihistamine as reducing gastric acid secretion, which could lead to ulcers and also esophagitis if the patient's vomiting. And it can also relieve the pruritus. Is it life-saving? No. So it's take it or leave it from me. So I can administer the antihistamine, and if I'm going to choose, I would probably choose chlorpheniramine, and if the patient's showing gastrointestinal signs, famotidine. If I don't have famotidine, ranitidine. But it's very much an ancillary treatment. The treatments that are the mainstay of stabilization of fluid therapy and a catecholamine. But let's talk glucocorticoids first, though.
Yes, that's the next one. Let's go with that.
Now, glucocorticoids, so neither, if we could administer these drugs before the patient was exposed to the allergen, they'd be extremely effective, right? But the problem is we're getting in after the horse has bolted. Now, again, like the antihistamine, the glucocorticoids may reduce the pruritus. But the other thing they may do, in anaphylaxis, it's important to remember that there's not just one mediator involved. What we see is mast cell degranulation, which leads immediately to massive histamine release. And that histamine is the primary early response where we get vasodilation, smooth muscle spasms, regardless of the different organs. We get the really profound signs on presentation. Mm-hmm. But what also happens at the same time is that membrane phospholipids are broken down. Phospholipase A2 is activated, and we see this breakdown of phospholipid membranes and liberation of arachidonic acid intermediates, the prostaglandins and the leukotrienes, which are really important a bit later on. We see some patients with anaphylaxis that seem to respond very well to initial treatment, but then remain quite ill for a period of time. And they're the patients where these more delayed mediators are involved, both the breakdown of phospholipids and release of the prostaglandins and the leukotrienes in the intermediate time frame, so sort of 6 to 8 hours. But then even later than that, we'll also see a cytokine response. One of the key cytokines is platelet activating factor, which can also cause a more prolonged illness because of this allergen exposure. And glucocorticoids may, by stabilizing phospholipids, help prevent that arachidonic acid cascade from getting crazy. So maybe worthwhile, but let's not administer. We're probably around administering an anti-inflammatory dose rather than any sort of immunosuppressive dose. So we're probably looking at 0.1 mg per kg of dex would be the dose that I would consider.
Okay. So to clarify, the dex that you're giving is not going to help for what has happened. That's not going to save the patient's life for what's happening now, but it may help for what might happen down the line still.
Yes.
I will also add the antipyretic effect is not negligible from a purely practical perspective, because I used to give dex like we all did for and I'm talking about the bee sting that comes in, maybe had a vomit, a fat face, but it's okay by the time it comes in, so it's not a hospital all night sort of a patient. And I used to give antihistamine dex, and that was the standard. And then I heard that doesn't really help, so I stopped giving them. And I had so many comebacks where they'd be back a few hours later or the next day. And why are they back in there with the angry client? Because it's itchy. It's scratchy. You can't get to sleep. And I'm like, okay, I'm giving dex again.
We're in the same boat there, and that's exactly what we've seen in our hospitals as well. We went through a wave of saying these things have no value, and then owners would come back with itchy skin and swollen faces and that. And eventually a veterinarian would, in emergency practice, right, you don't give it and you say there's no scientific evidence or whatever. And then the client goes to their local practitioner who they trust, who says, oh yeah, we'll give them this dose. And then miraculously everything clears up. And the emergency vet was a bit of a wally. So I certainly administer that. I guess I'm referring to the patient that I don't know is going to live till the morning. And I'm not worried about him getting itchy because he was, going to die otherwise. But swollen faces, itchy skin, absolutely.
Their dogs don't itch. From a personal point of view, I'm quite sensitive to these things. I'm not dying sensitive, but I get really itchy. And a bread tablet, and within half an hour I feel maybe not half an hour, but it definitely makes a big difference for that itch. Anyways, so that's treatment. So now adrenaline that's the mainstay of our treatment for the very anaphylactic dog. Let's first go back to the less severe ones. If you have that dog that had a vomit, had a bit of a wobble, and now has an itchy face, but it comes in and it's okay, do you still go for adrenaline there or not necessarily?
No, I only consider using adrenaline in patients with significant cardiovascular derangements. And if I know it's an anaphylaxis before, because the owner's been exposed to to an allergen, like they've seen a bee or they heard the dog cry out and then these signs presented, I would certainly consider using epinephrine early, but otherwise I would only use it if indicated. So many of the patients that don't have a history of exposure, we would treat with volume alone. But if we're convinced that it is anaphylaxis and we've still got volume issues, then I would definitely consider using this a little bit earlier. So it really depends on my index of suspicion as to how seriously affected the patient is, as well as how likely it is to be an anaphylactic reaction.
Adrenaline, its role in anaphylaxis. So clearly there's the cardiovascular effect that it affects the heart and helps and vasoconstricts. But I've read other things, or again, no in-depth reading. I've come across words like membrane stabilization and all those sort of things. Does it have other positive effects in anaphylaxis, or is it purely cardiovascular support?
Cardiovascular support and bronchodilation. The key in human medicine is the bronchodilation, because we die we asphyxiate with anaphylaxis. And my feeling of treating many patients with anaphylaxis over the years is that actually adrenaline is not as imperative in canine anaphylaxis as it is in people. In people, they, you die very, very quickly and the EpiPen is life-saving. In canine anaphylaxis, volume replacement seems to be extremely important, and fluids alone treat many of the patients that we see with anaphylaxis. So it certainly has a role, but we are usually using it as a slow IV infusion, about 0.05 microgram per kilogram per minute. And we certainly see many patients that respond to fluids alone.
Okay.
So it's not, it's written up as a cornerstone of treatment in all of the texts and the academic writing around anaphylaxis, but I don't feel that it's life-saving in the way it is with humans, where an EpiPen makes the difference between life and death.
I went to a talk probably 5 years ago on specifically this sort of bee sting reaction.
Mm-hmm.
And the feeling there was that if there's any systemic signs, so vomiting
Mm-hmm.
or any episode of weakness, even if they present looking okay, that they would still administer just an IM jab of the low dose adrenaline. The protocol was injected and then injected again about 20 minutes later. So I had started doing that for anything that, and sometimes they'll come in and they're not dying, but they're still a little bit pale, like dogs wagging its tail, but it's maybe a bit tachycardic and the gum color is not fantastic. And with those, the low dose adrenaline IM, and within 10 minutes, they pink and they look heaps better. And then those I'll admit and monitor for 6 hours or so, and they tend to just be fine. Does that make any sense, or has the thinking changed about it, or?
When it was studied, actually giving IV boluses of epinephrine for treatment of anaphylaxis, the only thing that made a significant difference to the cardiovascular parameters was a CRI. There was a transient improvement when you give an IV bolus, but it's gone back to normal baseline pretty quickly. And then in some situations where the hypotension's been going on for a little bit longer, some studies have shown no positive benefit at all to adrenaline on mean arterial pressure. So I think the jury's still out, Hugh. The only thing with adrenaline is never give it subcutaneously. That's, it's a short-acting compound. You're only lasting 3 to 5 minutes maximally. So your IM dose is having a very short duration of effect. And, if it makes a measurable difference to the patient, then no troubles at all. But it's not something that I typically administer unless we've got significant cardiovascular signs.
Okay, cool. And so how do you give it? So you're reaching for CRIs, is that right?
Reaching for CRIs. What we may do, or what I will sometimes do, is administer a 0.01 mg per kg dose IM. If that high index of suspicion, if we're rushing to stabilize this patient, get an IV in, and we're fairly confident that the patient's got anaphylaxis, I may administer IM while I'm stabilizing. But typically what we do is just use a CRI at about 0.05 micrograms per kilograms per minute.
Okay. And how long does that last for? How long do you do that for?
We'll keep them on that CRI until the patient's cardiovascular parameters have, normalized. Again, there's always a risk reward with these things. Vasoconstriction is not innocuous, and neither are the cardiac effects of the adrenaline. So when I'm, weaning any catecholamine, what I do is generally make sure that we've got resolution of the reason that we put them on there. So this patient with anaphylaxis, I'd expect, normal mean arterial pressure, at least over 60, and resolution of the signs of shock. And then what I would do is halve the dose and keep the patient on that dose for an hour, then halve it again. So usually we'll go for about 2 hours in any weaning situation, halving the dose, and you're giving, essentially nothing at the end of that time. But the idea being that as soon as, if any signs reoccur, you can crank back up again. And I use that kind of rule of thumb as well when I'm managing post-operative hypotensive patients or anything like that. If we've normalized the reason that we've got them on the catecholamine, halve the dose, see what happens over the next hour, and I generally will reduce that dose twice by half before I think about discontinuing it.
Okay. And while they're on that, at that dose, are you going to see, because I know in the old days with a solid old IM dose, or into the heart, like on Pulp Fiction.
Yep, yep. I used to do that too.
You get a massive tachycardia from the adrenaline. On that CRI dose, are you seeing a noticeable tachycardia?
Not a noticeable change in many patients. And really, you want to, that's a starting point, Hugh. So if you're sure you've given enough volume and you're still hypotensive, you can crank it up. What I see more, as commonly as tachycardia is bradycardia, depending on the effect on actually what's going on with the patient. So if you've got an extremely hypotensive patient and suddenly we cause massive vasoconstriction and increase the blood pressure, you can actually get a rebound bradycardia from adrenaline too. So it's a very variable response just depending on the systemic status of the patient. And so what I do is see what you get from what you give and then tailor the drug dependent on that.
Well, so there's a very good reason I asked that, because one of the clinical parameters for seeing are you treating the shock effectively is the tachycardia improving. So I wanted to just double check that if the patient still has tachycardia, don't go, oh, don't worry, it's just the adrenaline. You go, no, actually, it's still in shock. I need to rethink this.
You want to go very carefully with every one of these patients is an individual, and you're going to look at the cardiovascular physical parameters, but also the lactate level and also the mean arterial pressure. And between those things, we should be able to balance the need for pressure and the need for oxygen delivery by not causing too massive a vasoconstriction. And that should, we're aiming for that mean arterial pressure of better than 60 and a lactate that's trending down or at least halving in the first couple of hours.
You know those conversations that you have at conferences, back in the days when we still had big vet conferences, when people are chatting to the lecturers and asking questions, and you hear things like, this isn't really in the books, but here's what I think. It's in those kinds of conversations that the best nuggets of wisdom appear, the nitty-gritty real-life details that you can only get from years and years of experience. And it's exactly those kinds of conversations that we try to emulate on the Vet Vault Clinical Podcasts. We don't want lectures. We want to hear about the challenges, the tips, the stuff-ups, this is how I do it. Go to vvn.supercast.net to join in the conversation.